Welcome back to another episode of HealthCap Weekly Wrap. This week, we're talking about a Pennsylvania neglect investigation, a Maryland bill on medical directors, a big wave of federal quality and oversight pressure, a very practical antipsychotic quality measure resource, and a new white paper on where accountable care may be headed for long-term care residents.
Yeah, and there is a pretty clear thread running through all 5 stories. It's accountability. Who is watching care closely? Who is documenting it correctly? Who is leading clinically, and how communities are going to operate in a world where quality data and oversight matter more and more.
So let's start in Pennsylvania with CBS Pittsburgh. The article is titled 15 Residents at Pennsylvania Senior Care Facility Sent to Hospitals Amid Neglect Investigation. Pennsylvania State Police said they opened an investigation at Belle Reve Senior Living Facility in Milford Borough after an anonymous tip, alleging suspected medical neglect of residents. After on-site assessments, 15 residents were taken to 4 hospitals for evaluation. Police said the investigation was ongoing, and they also said there were no known unmet needs at that time.
Oh, and when you hear a number like 15 residents transported out of one community, that gets your attention fast. This was not a single resident event. According to CBS, it required a coordinated multi-agency response involving emergency management, fire and EMS resources, county detectives, and the Pike County Area Agency on Aging. That alone tells listeners this was a serious operational moment, even while the facts are still being investigated.
Right. And one thing I want to say carefully here is that an investigation is not a final finding. We do not know the outcome yet. But for senior care leaders, the takeaway is still very real. Anonymous complaints matter. Response time matters. Clinical follow-up matters. And when concerns involve multiple residents, the situation can widen very quickly beyond the walls of the community. A local follow-up report in Pike County also said the community had been operating on a provisional license issued in December 2025. And the paper reported that state officials said that licensing action was separate from the February 2026 investigation.
Yeah, and the practical lesson for operators is not to wait for a crisis to test your systems. Are changes in condition being escalated? Are family concerns documented and answered? Are outside providers looped in? Is leadership looking for patterns across residents instead of treating each concern like an isolated event? Because when public agencies arrive, they are not just looking at one bad day. They are looking at the community's ability to recognize and respond to resident needs.
The second story moves from an active investigation to the question of clinical oversight. McKnight's reported on a Maryland bill titled State Bill Limits SNF Medical Director Coverage, Adds Training Rules. The proposal would require a physician serving as a nursing home medical director to meet certification requirements or show active progress toward certification, would limit one physician to serving as medical director for no more than 2 licensed nursing homes, and would require Maryland to create an online public directory of nursing home medical directors and their credentials.
And this is where the conversation gets interesting because the article did not frame it as a simple yes or no fight. It included stakeholder concerns about whether the 2 community cap is practical, especially in a market where medical director availability is already limited. The piece also connected the bill to broader scrutiny of medical director engagement, and that lines up with current OIG work. OIG says nursing homes are required to report medical director hours in payroll-based journal data, and that those reported hours have raised concerns about employment and engagement of medical directors.
Yeah. So one host reaction here is, oh, that sounds good. More accountability. But the expert reaction is, okay, can the workforce support it? Because if a state tightens the expectations, communities still need enough qualified physicians willing and able to serve in these roles. And that is really why this matters to senior care. Clinical leadership on paper is one thing. Actual presence, responsiveness, and influence on quality systems is another.
And for listeners, the takeaway is to look at the medical director role as part of daily operations, not just governance. Is your medical director visible to the team? Are they tied into quality assurance? Are they helping with physician services, medication oversight, and resident care policies in a way staff can actually feel? Because if states and federal agencies are paying more attention, communities will want that role to be strong before rules get stricter.
Okay, story 3 is the broad policy one, and it comes from Skilled Nursing News. The title is CMS Clarification Increases Risk of Nursing Homes Falling Below 90% QRP Threshold. Now, yes, the headline is about the SNF Quality Reporting Program threshold, but the article also looked at a bigger compliance landscape, and that makes it relevant beyond one technical rule. CMS already says providers can face payment consequences if they do not meet SNF QRP submission requirements, and the reconsideration and exception process is a live issue on the agency's site.
That's right. CMS says the SNF value-based purchasing program is continuing to expand. On the CMS payment systems page, the agency says SNF VBP will expand to 8 measures starting in fiscal year 2027. And for fiscal year 2028, the program adds a skilled nursing facility within stay potentially preventable readmission measure. CMS also says the fiscal year 2027 confidential feedback reports include 8 quality measures in the baseline period. So when Skilled Nursing News talks about QRP, VBP expansion, and pressure building all at once, that is very much in line with what the federal program pages are showing.
And then layer on oversight. OIG says it has a series of audits underway to determine whether Medicare payments to SNFs under PDPM complied with Medicare requirements. OIG also issued a 2025 report saying the Special Focus Facility program had not yielded lasting improvements, and CMS revised the SFF memo in January 2026, with changes aimed at communities staying in the program too long and communities showing repeat noncompliance after graduation.
So why is this important to senior care listeners? Because the environment is getting less forgiving. Data submission, measure performance, public reporting, validation, audits, special focus rules, all of it is becoming more interconnected. A community can no longer separate reimbursement from quality, or quality from documentation, or documentation from survey risk. They are all talking to each other now.
Exactly. And the listener takeaway is pretty direct. Leaders need someone in the room who understands timelines, data integrity, MDS process, claims implications, and how quality scores are being built. This cannot sit in one silo. It has to be a team sport between operations, clinical leadership, MDS, reimbursement, pharmacy partners, and compliance.
That brings us nicely to story 4, because this one is all about the work at the resident level that drives those outcomes. The American Healthcare Association released the tip sheet called Percent of Long-Stay Resident Who Received an Antipsychotic Medication. Now, this is not really a casual fact sheet. It is much more like a working guide for teams. And around that release, AHCA and provider both explained that the revised long-stay antipsychotic measure uses MDS data, along with Medicare and Medicaid claims data. And AHCA also said the revised measure started public reporting on Care Compare in January 2026.
Yeah, and that detail really matters because the old instinct might be to think, okay, just code carefully and we'll be fine. But the newer message is broader than that. As Provider put it in its recent article, communities have to respond differently, not only by coding accurately, but also by managing medications more deliberately. So this is about assessment, diagnosis, supporting documentation, monitoring behavior, reviewing whether a medication remains appropriate, and making sure the care team can defend the clinical picture reflected in the record.
And this is one of those stories that might sound technical until you realize how resident-centered it actually is. Antipsychotic use sits right at the intersection of behavioral health, dementia care, documentation quality, survey risk, and family communication. If a community gets this wrong, it is not just a score problem. It can become a care planning problem, a pharmacy problem, a survey problem, and a trust problem.
The takeaway here is simple. Communities should not treat the updated measure as only an MDS issue. It is a whole clinical operations issue. The resident's diagnosis, behavioral presentation, gradual dose reduction considerations, physician documentation, interdisciplinary review, and follow-through all matter. And for listeners, this is probably the most immediately actionable story of the week because teams can do chart review, education, and auditing work on this right now.
Our fifth story zooms back out to strategy. AHCA NCAL released a February 2026 white paper titled Advancing Accountable Care for Long-Term Care Residents, Recommendations from their ACO workgroup. The paper says it is intended to inform CMS as the agency finalizes the long-term enhanced ACO design, or LEAD model. The white paper argues that long-term care residents have distinct clinical, functional, nutritional, and social needs, and that accountable care models for this population should reflect those realities instead of borrowing a framework built for community-dwelling beneficiaries.
Okay, why should a senior care operator who is already buried in staffing, surveys, reimbursement, and resident acuity care about an ACO white paper? The answer is because this is about whether future payment and quality models are designed with long-term care in mind or without it. This paper recommends facility-based attribution tied to TIN or CCN, and the long-term institutional flag, flexible risk sharing, more predictable benchmarking, streamlined quality measurement, and better support for data sharing and interoperability.
Yeah, and CMS has already said LEAD is a 10-year voluntary model that runs from January 1st, 2027 through December 31st, 2036, with applications beginning in March 2026. So this white paper matters because it lands at the exact moment CMS is building something new. AHCA NCAL is basically saying if you want accountable care to work for residents in nursing and assisted living settings, then the model has to recognize who these residents are and how care is actually coordinated in these communities.
I think that is the perfect closing thought for the episode, because all 5 stories connect. The Pennsylvania story asks whether resident needs were recognized and addressed. The Maryland bill asks who is clinically accountable. The skilled nursing news piece shows that federal quality and payment systems are getting tougher. The antipsychotic tip sheet shows how detailed the daily work has become. And the AHCA NCAL white paper asks whether the next generation of payment models will finally fit long-term care better.
Exactly. So the big takeaway for senior care professionals this week is that strong resident care, strong clinical leadership, strong documentation, and strong policy awareness are no longer separate conversations. They are the same conversation. And the communities that do best will probably be the ones that connect those dots early, instead of waiting for a survey, an audit, or a crisis to connect them for them.
Thanks for tuning into another episode of HealthCap Weekly Wrap. For more details on these stories, you can find the weekly roundup on Angie's blog at healthcapusa.com/Angie's blog.
We'll be back next week with more stories shaping senior care across the country.
Take care.